I know, but it's like.
Okay, I think we can get started. Thank you all for being here. Welcome. For those of you who don't know me, I'm Sarah Knight. I am a faculty member in preventive medicine, and I'm the director of the Health Services Research Program at the VA. And we're doing this Works in Progress seminar as a part of a series of seminars and panels that we're doing to strengthen our grants as we get ready to submit our VA grants. So these are all done on a just-in-time basis, not a lot of advance warning, but when each investigator is ready. Because this is to help someone prepare for a grant submission, your feedback is very much appreciated, and we're very grateful that you're all here, and we are going to be very excited to hear what you think. Also, because this seminar series is a new one, coordinated through the core, we would welcome any feedback you have on how it's organized and when you receive the announcement and so on. But we do want to let you know that we know it's a just-in-time format that we needed in order to help the investigators get feedback in a timely way. So I'd like to introduce our presenter today. I know many of you already know Dr. Melanie Morris, but some of you don't. And so I'll just make a few remarks about Melanie. I was really delighted to meet and start to get to know her since I arrived here last year. Dr. Morris is a native of Tennessee and a graduate of Vanderbilt University. Her medical degree was through the University of Tennessee at Memphis, and she did her colorectal, her general surgery training at Oregon Health and Science University in Portland, Oregon, and her GI surgical training through Baylor University in Houston. She's currently an assistant professor at UAB and is the chief of general surgery at the Birmingham VA. And Dr. Morris's interests are in health services research, surgical outcomes, and quality improvement. Thank you very much, Dr. Morris.
Thank you, Dr. Knight, for that kind introduction. So I want this to be very informal, and I'm looking forward to any feedback or suggestions that you may have. So these are kind of my objectives. So I'm actually going to review the work that we've done on readmissions and sort of explain some of that as the background of how we've gotten to the idea about prehabilitation. I'm going to sort of define and describe what prehabilitation is, and then outline my current pilot project plan that will be submitted in June. And I welcome any feedback or suggestions again. So readmission is a hot topic these days. Readmission rates are now publicly reported at the hospital level, and they have financial implications. So the Center for Medicare and Medicaid Services currently penalizes hospitals with higher than expected rates of readmission for congestive heart failure, myocardial infarction, pneumonia, chronic lung disease, joint replacement, and cardiac bypass surgery, with plans to expand both the medical diagnosis and the surgeries included in this. And last year, 54% of U.S. hospitals were financially penalized. So penalizing these hospitals assumes that postoperative readmissions are preventable and that readmissions are indicative of the quality of care during an index hospitalization. If we could predict readmission, that would allow for targeted interventions to hopefully prevent them. So determining the risk of and reasons for readmission after surgery is really difficult. And prior published studies use big administrative data to study readmission. The Veterans Affairs data is actually ideal to study readmission because most veterans receive all their care and medicines through the VA. Laboratory data, prior healthcare utilization, medications, and vital sign data are all available, which you can't get from retrospective analyses of large databases. So the specific aim of our study with the readmission work was to understand the relative contributions of patient factors, operative characteristics, and postoperative hospital course on unplanned 30-day postoperative readmissions. We performed this with a retrospective study of a VA surgical quality improvement cohort. This included inpatient, general, vascular, and orthopedic surgery patients had a postoperative length of stay of greater than 2 days. The patients had their hospital stay between October 2007 and September 2014, and we excluded patients who died. We then categorized our variables into the groups preoperative, operative, postoperative but pre-discharge, and post-discharge. The data sources we used were VASQuip, which collects preoperative, operative, and postoperative variables, and the corporate data warehouse, in which we can collect laboratory values. We examine the closest pre-op and the highest and lowest post-op of a large number of laboratory values, and vital signs for patients, including pain scores from 30 days pre-op through hospital discharge. We also use the CDW to obtain socio-demographic factors such as marital status and insurance coverage, and the CDW inpatient and outpatient data for prior healthcare utilization such as emergency department visits, primary care visits, mental health, and post-discharge admissions. We defined readmission using administrative data as in 30 days following discharge, and readmission reasons were classified by ICD-9 codes and reviewed by 3 clinicians, 2 of whom are sitting in the room. We performed univariate and bivariate statistics, multivariable logistic regression modeling, and we constructed these models by sequentially adding the groups of variables, and we compared our models using R-squared and C statistics. So what did we find? So we found almost 240,000 surgeries that were performed at 121 VA hospitals over this time period. We had an overall 11% 30-day readmission rate. This differed significantly based on the type of surgery. Vascular surgery patients had the highest readmission rates at 15%, followed by general surgery at almost 13%, and orthopedic much lower at 7.5%. The top 5 procedures accounted for 50% of the cases, and these were knee arthroplasty, colorectal resections, hip replacements, cholecystectomies, and peripheral vascular bypass. These are the demographics. As you would expect in a VA cohort, most of them were white men. Almost half of them were married. Almost all the patients were admitted from the community or an outpatient setting. 13% had an ASA classification of 4 or higher. 10% of the patients were classified as partially or totally dependent functional status. 17% had a history of depression, 26% non-insulin dependent or insulin dependent diabetes. The average hospital length of stay was 6.9 days, and 6.1% of these patients experienced a postoperative complication while still in the hospital. This graph shows the daily hazard for being readmitted. The vascular surgery patients are in red, the general surgery patients are in green, and the orthopedic patients are shown in blue. And as you'll see, most, and the x-axis are days since hospital discharge. As you'll see, most patients are readmitted within 2 weeks of surgery, but general surgery patients are most frequently readmitted within 1 week of surgery, following discharge, not surgery, following discharge. And then it drops greatly after that. For vascular surgery patients, the risk stays high out to 30 days. We looked at readmission reasons, and the most common reason for readmission were wound complications. Sorry, didn't transfer. And followed by GI complications, which included ileus and obstruction. So then we performed our modeling, and again, we grouped the factors into preoperative data. So these are patient demographics, patient comorbidities, social behavioral, preoperative labs and vitals, and planned procedure type. And including all the preoperative data, we could only explain the variation in readmission 8.6% of the time. And as you'll see on this chart, the social, behavioral, and comorbidities contribute the most. When we included operative data such as procedure complexity, other operative characteristics, we had very little additive predictive value. And when we included postoperative cores, including pain scores, labs and value, vital signs, discharge destination, our model improved to 10.2%. We could predict the variation in readmission. So again, not very well. So if we include post-discharge complications and ER utilization, again, these are things that you would not know at the time of hospital discharge, but our predictive model increased to 18.6%. And this graph shows both the R-squared and the C statistics, and again, you'll see sort of the slopes increase the most with demographic comorbidities and then with post-discharge data. So what did we conclude from this big study? So readmission is difficult to predict at the time of discharge despite exhaustive statistical modeling with granular clinical patient-level detail. Preoperative patient factors and post-discharge complications contribute the most to predictive models. And so efforts to decrease readmission should focus on modifiable patient-level risk factors, transitions of care, and minimizing post-operative complications. So this is where the idea of prehabilitation comes in. So prehab, the theory of prehab originated in sports medicine, where athletes would train intensively before a competition to try to prevent injuries. Prehabilitation is also defined as the process of enhancing functional capacity of an individual to enable him or her to withstand the stressors associated with major surgery, cancer treatment, etc. So my definition of prehabilitation is targeting modifiable risk factors which are associated with poor surgical outcomes and designing a patient-specific preoperative intervention. So the idea of prehabilitation is really a hot topic these days. There's actually really a paucity of literature surrounding prehab. Most of it comes out of the United Kingdom and Canada. Most of it are small case series. Some are randomized controlled clinical trials. It mostly surrounds exercise and mostly in orthopedic patients. There was a Delphi panel in 2015 that was published on colorectal cancer surgery patients. Again, this was in the UK. And the only statement they could agree upon was that exercise training should form part of preoperative care and would be supported by surgeons. So the state of Washington has actually implemented a prehabilitation program. It was piloted at the University of Washington and then implemented kind of statewide with Blue Cross Blue Shield as part of the payer for all this. This is their website. It's becertain.org. I think they've done a really good job of organizing it. What they focus on are 4 different efforts to intervene preoperatively. You can see them listed here at the bottom. So one is nutrition, one is glycemic control, one is smoking cessation, and then medication management. This is an example. So if your patient were a smoker, you would go to the website, you would check on smoking cessation, and this is what comes up. So this would be the patient-specific checklist. So do they smoke? Yes, they smoke. And then the options would be down at the bottom. Here are some, I've referred the patient to either freedom from smoking, plan to quit, become an X, or 1-800-QUIT-NOW. So that's just an example of one of their interventions. So I think Strong for Surgery is great. I think there are a lot of positives. It addresses important risk factors like smoking, medication adherence, diabetes management, nutrition. I think it's well designed with really good patient educational materials. And I think overall it's bringing awareness to this whole idea of prehabilitation. I think there are some things that could be improved upon. The patients are really referred for these interventions. The interventions aren't integrated as part of the plan for the patient. They're not in the private practice surgeon's office. And it's unclear how much they're tracking adherence to and outcomes from these interventions. And it really doesn't address things like frailty, functional status, and obesity, which I think are really important, and I'll talk about a little more. So I think the VA is actually a great place for prehabilitation to work because, again, most veterans obtain all their care through the VA. Some of these services already exist within the VA, such as tobacco cessation, the MOVE program, their dietitians, their pre-anesthesia clinics, and again, it's all one medical record, it's all one location, so it would be a good way to integrate that care. So I think it would be great to utilize these existing resources or redesign others to incorporate prehabilitation. So if I could have a dream to design prehab, here are the things that I would focus on as sort of a lofty goal, big picture. So I think frailty is extremely important, and I'll talk about this more. And frailty is also a very hot topic in surgery these days. We know that functional status predicts poor postoperative outcomes, including mortality, but it's not very specific. And frailty measurements are much more specific, and I'll talk about that a little more. But in general, frailty encompasses functional status, exercise tolerance, and cognitive assessment. I think smoking cessation is important, nutritional assessment is important, and not just malnutrition. We need to be discussing obesity and diabetes as well. Mental health is important and has been shown to affect postoperative outcomes, and medical comorbidities. So again, just to go back to our readmission study and highlight how readmission as one measure of postoperative outcomes, how these factors relate. So frailty, so in our patients that we examined, functional status, if the patient were independent, they had a 10% readmission rate. If they were partially dependent, 18%, and if they were totally dependent, it went up to 21%. If they had impaired sensorium preoperatively, their readmission rate was 22%, and if they were admitted from a nursing home, it was 21%. Patients who were smokers within 1 year of surgery had higher readmission rates, and nutritional assessment. And when we were assessing nutrition, albumin stayed in the model and was one of the larger predictors of readmission. Diabetes increasing to oral hypoglycemic agents or insulin increases your readmission risk. Mental health is a big predictor of readmission as well. Patients with depression had a 12% readmission rate, bipolar 13%, psychosis 16%. And then medical comorbidities, especially congestive heart failure, COPD, previous MI, hypertension, peripheral vascular disease, acute renal failure, and progressive renal insufficiency, and that would be preoperative progressive renal insufficiency. Those patients were readmitted half the time. So, yeah.
Obesity involved? Not at all.
So we didn't do a very detailed analysis of obesity in our readmission group, but that's a great question. We have looked at a NSQIP cohort with the primary outcome of interest being surgical site infection rates and the others being mortality, readmission. And it's interesting, surgical site infections, sort of as you would expect, there's a linear relationship even when you break it down into sort of class 1, 2, and 3 obesity. Most surgical literature just defines obese and non-obese instead of breaking it out into those categories. But we didn't see the same escalation in readmission rates. We looked at that. Oh, so frailty. So again, frailty I think is really important. And this article from JAMDA was, they came up with a consensus. And this was, again, it was a multinational consensus. And most of the work is being done in Europe and Canada. And they define frailty as a clinical state with increased vulnerability for developing increased dependency and or mortality following an intervention like surgery. So physical frailty is an important medical syndrome. It can be prevented or treated. It's different than things like disability because you can have a disabled patient who is or is not frail. There are simple validated tests like FRAIL, which I'll talk about more, to define frail patients. And all elderly patients greater than 70 years or any patient with significant weight loss should be screened. So that was sort of an expert consensus on frailty. This is one example of a frail scale. This is the clinical frail scale, and that may be a little hard to read, but I'll just sort of highlight the important points. So patients are either very fit, they exercise, they're appropriate for their age, they're well, they don't have significant medical comorbidities, they occasionally exercise. They're managing well, they just walk around a little bit, but they're doing okay. Vulnerable, so they're slowing down a little bit, but you wouldn't call them as partially dependent or totally dependent, which is again how most surgical literature defines functional status, either NSQIP, VASQIP, those things. Mildly frail, which again, you wouldn't even call this partially dependent, and it would be moderately frail, like this number 6. You might call those people partially dependent, and then severely frail, they would still fall into our partially dependent functional status, and very frail. So these people would be the completely dependent functional status. So I think that kind of highlights how just talking about functional status alone is not descriptive enough, and that frailty is a better way to talk about it. So what about frailty and surgical outcomes? So there was a systematic review of 31 studies of frailty in elderly patients. The prevalence in those studies ranged from 4 to 17%. And this and other studies have shown that frailty alone is an independent predictor of increased length of stay, postoperative complications, and mortality. And interestingly, in this paper from the Annals of Surgery, they talk about frailty is something that is intuitively recognized by physicians, but we really lack standard definitions or assessment tools, so we don't use it as part of our perioperative management or counseling. It's really sort of a gap, I think. So that gets to the point of this study. So this is my specific game number 1, is to determine the rate of frailty in a national VA surgical cohort and define the relationship between frailty and surgical outcomes. Yes,
Sorry to interrupt.
please.
I just noticed you didn't factor in age in the original model.
Mm-hmm.
Do you have some data to make you think? I get frailty, but was there some age differences that you saw in that model? Age alone.
For readmission?
Mm-hmm.
We didn't really.
We included age,
But it didn't.
fell out.
Yeah.
Which means it was probably explained by other things that are kind of correlated with age.
Yeah.
Age categories or age? Like comorbidities, like as you age, more likely to develop some of these like CHF. Yeah, it's just an interest because aging and frailty are so linked.
Right. But I completely agree with that. But I think that because they're not, you don't have to be old to be frail. I think we ought to screen everyone for frailty, especially. I think I'll talk about that in just a minute. Within our surgical population, because a lot of patients have cancer, other diagnoses.
It's not age alone, you're correct. But I'm just thinking as a geriatrician. That's our target population.
Yeah, so we actually looked at, I'm just going to talk about a frailty index that we looked at. We did stratify different age groups, and there was a correlation, as you'd expect. The total frail scale was higher among those older populations, but you still had a significant amount of people that were less than 60 that they were still picking up some frailties. I think that's, so we looked at it, but I think she's going to kind of go more into that. But that's definitely a good
be in
point.
the absence of just comorbidities.
Right.
Too.
Mhm.
Like cancer is a major piece of that, but you can have it without.
So I think that's an excellent point. And so I think we ought to use a cohort similar to the one we've done our readmission work on. That would be my plan for specific aim 1. And to go more in depth, we did go back and calculate a modified frailty index on those patients. And so we have some sort of preliminary data, but I think we need to sort of model all the surgical outcomes with all the frailty indices. And I'm glad you're a geriatrician because that's great. I need your input. So again, with specific aim 1, so our hypothesis would be that frail patients will experience higher rates of postoperative morbidity and mortality. And again, we would use a similar retrospective VAD cohort undergoing major surgery. We've already started calculating the modified frailty indices, stratify patients with our sort of primary outcome as being mortality, and then secondary outcomes of our traditional sort of surgical things we measure with readmissions, discharge destination, and the VASCOP assessed surgical complications. And then we would use similar data sources as what we described in our readmission work. And so this is the modified frailty index, which you will obviously know well. Some of the surgeons in the room will not. But the reason that we picked the modified frailty index is because you can actually calculate it retrospectively. I think it has some gaps, and I'll talk about those. So history of diabetes, history of congestive heart failure, history of hypertension, TIAs, functional status, again, which is not specific enough, myocardial infarction, peripheral vascular disease, CVA, COPD, prior angina, and impaired sensorium. And again, the modified frailty index was developed because they wanted to look at a large retrospective cohort. It wasn't designed prospectively, as you would know. So I think the pros are you can calculate it on, large retrospective cohorts. It is validated, but again, I think it's not specific enough. So what specific aim 2 would be to implement a frailty assessment tool into the preoperative assessment at the Birmingham VA. So you can judge my tools. So what do you want in any kind of tool you're going to implement? It should be valued, reproducible, specific. It should be changed over time if you need to. Practical, non-invasive, not costly, accessible. It should predict what you're actually trying to predict and be adapted for several patient populations. So I heard that the VA already had a frailty calculator, and I got really excited. It turns out it is a mortality calculator and the same as the NSQIP mortality tool. So I found that out last week, and then I got my hopes up, and then they were dashed. But so the VA is already thinking about things like risk calculators and implementing them, and that's from the National Surgery Office. So I think we ought to use the frail scale. What do you think about the frail scale?
I think we have to be careful that it's been validated in your population.
Yeah, so I think we ought to use that and the study of the osteoporotic fractures, capillary frailty, because they overlap a little bit. And then you'd have two validated things, but I don't know. I'm open to suggestions. So the frail scale, you just ask the patient, you know, do you have fatigue? Can you climb up a flight of stairs? Can you walk down? Can you walk one block? If you have greater than 5 illnesses, that's easy to calculate. And then how have you lost weight recently? And then you're either pre-frail or frail. And then the SOF scale, so again, it's weight loss, and can you stand up from a chair 5 times without using your arms? So that's something you can actually test patients with and do, and they do feel full of energy. So I think so there are some other frail scales that test things like grip strength, but again, you have to have equipment, which is expensive, and then are people using it correctly? And there are other tools, but I don't know that they give you more information, and they're a lot more labor intensive. So again, to do this specific game too, you know, we'd like to implement the frail scale and the SOF scale into the preoperative assessment of general vascular and orthopedic surgery patients undergoing elective surgery at the Birmingham VAMC. And we're already doing some amount of preoperative assessment that gets documented in the electronic medical record. The questions would be whether this is done in the surgery clinic or the anesthesia clinic, and it could be either, depending on how we want to do it. So I don't know if you have any other thoughts, concerns on that. I talked to Kelly Flood and Katrina Booth, and Katrina thought that those were the best two. And there's no consensus in the surgical literature at all on what frailty scales you should use.
Currently using one in there that escapes me, but I can send it to you in a multi-center clinical trial for pelvic floor surgery. To look at outcomes pre, post, in a big surgical intervention on multi-center sites. I can see what they chose and why. I'd be happy to share it with you.
Great.
There has been some data, I think, on that one in the surgical population.
And then Hopkins came up with the Hopkins frail scale, and that's what they use, but other people haven't adopted it, so it's hard to...
It's balance between feasibility and
That's right.
utility for measurement.
Right. And something that, you know, pelvic floor surgery is quite complex, and a lot goes into that anyway, from sort of social, behavioral factors, but and what you might choose for a clinical trial, working on a complex thing, may not be the best thing to implement in everyday practice at a VA. So yeah, I don't know what the right tools are. After sort of talking to some people who do a lot of work in this area, we kind of came up with those too, but certainly open to suggestions. And then so my specific aim 3 was to design and implement an intervention to improve exercise tolerance in the preoperative period. So I was very excited about this, and I was going to refer patients to the MOVE program to improve their exercise tolerance and nutrition prior to elective surgery. Well, that's not going to happen. So when we met with the people in the MOVE program, there was a lot I didn't understand about MOVE, but they currently only provide one class a week that has 10 minutes of physical activity during that class. And that's the only thing they have. They don't have physical therapists available. They don't have any physical space where they can even let people exercise. They have no exercise equipment. They are mostly focused on weight loss by providing things like recipes, support, education. And interestingly, the veterans, for those of you who work with veterans, you know, veterans are likely to show up for appointments if they're going to get their travel paid for. And to go to things like MOVE, they only get half of their travel pay, which I don't completely understand. It's a voluntary appointment, not a mandated appointment. So my specific aim under number 3 is still sort of in flux. So we thought about a lot of different things. Could we utilize inpatient physical therapy services for outpatient preoperative therapy? I don't know, they have such limited space at our Birmingham VA, and I don't know if they have capacity, but I'll talk to the physical therapist and see what they think. The MOVE coordinator did tell us that there was a recent national VA memo encouraging a relationship between veterans and YMCAs. And, you know, could we utilize this? But who would pay for membership? How would veterans get there? Our veterans who have surgery at the Birmingham VA travel from all over the state. So they couldn't come to Birmingham to go work out or walk on a treadmill or do something. And then maybe we should just refocus AIM 3 and for now sort of track compliance with our frailty assessment tool and track postoperative outcomes, you know, over time as we're implementing that tool. I think that's all that, yeah.
What's like the target population for the people for the intervention? Is it going to be like people that are super frail or everyone or obesity?
I think it would be pre-frail or frail and see if you could improve, you know, I don't know if you would retest. You'd have to decide. Would you retest? Possibly. You may not move the needle very far, but there are some studies that show that walking even 2 weeks before major colorectal surgery had some benefit on postoperative outcomes. So shorter length of stay and less complications.
And that was my other question for the time frame. Like how far preoperatively?
Yeah.
You want people to.
So I think it depends on the indication for surgery. So like what they do with strong for surgery, even 80-year-old grandma who has colon cancer, they talk to them about we need to make her strong for surgery. So these are the things that we need to be working on so that she's going to do the best she can. And so I think, you know, I think somewhere a 2 to 4 week timeline is reasonable of things to have patients do before surgery. Some of that would kind of depend on the surgery scheduling of how long they could do the intervention before. And then for things like large ventral hernias, which are completely elective surgeries, you can make that a longer time period of those patients, again, they're not necessarily the frailty cohort, but that would be in my dream world of dealing with the obesity and diabetes. You would intervene on them longer before surgery.
I know we talked about it. I don't know how feasible it would be, but what about speedometers? Like being able to get someone a speedometer and then you'd have all the access to like how far they're walking and how long, and that's, I mean, relatively inexpensive and they wouldn't have to come back as much. And
that's a great point. We thought about that too. You know, now that people have all this Map My Run, you know, is there a way that you can just give them a pedometer or something to track progress, or even, you know, just kind of journaling, which, you know, it's all just patient reported. So it's, you know, you can cheat the Fitbit too if you shake your arm around. So it's not a perfect tool for sure. Yeah. Yes.
Melanie, this is really great work, and just seeing it presented for the first time all integrated is wonderful. I was really curious, though, whether or not you make surgical recommendations based on observations of frailty. So, for example, you see a patient who has severe frailty and you may decide that they're not able to tolerate the surgery. And it may be that at various levels it influences the decision-making in different ways. Is that the case?
That's absolutely true, and it's very hard to quantify for us. So if surgeons had a better language to use to talk about frailty and a better way to predict it, it certainly impacts our decisions. I saw a patient last week who I've been following for a long time, who's he's not 65 yet. He seems like he's 80. But he has rectal cancer, and he's had a surgery in the past. He's had a recurrence. He's a smoker who has COPD, who's had significant weight loss because of both his cancer and his cancer treatment. And he has a recurrence in his pelvis, and surgery is going to be a major surgery, and we're not even sure we would be able to get all the tumor out. So there's the issue of, you know, causing significant harm to this patient, and we may or may not provide him benefit because we don't know if it's completely resectable. And so I had a frank discussion with him last Wednesday, you know, as I'm researching all this and thinking about it. And so we came up with the plan, because he can't stand up out of the chair 5 times without using his hands. So I had him do that. And then we talked about how that's going to make it really hard to get out of the bed after surgery. So he's going to go walk up and down stairs and try to increase his exercise tolerance for the next 2 weeks. And I'm going to see him back, and we're going to make a decision about whether we're going to operate or not, jointly. So I think it has huge implications. It's just really hard to do, I think, and that's why everyone's talking about it, but it's hard to figure out how to, since there's no consensus on which frailty assessment tools are the best. And
I have a question. What, from a geriatric standpoint, what do y'all recommend? Or like, so in a similar relationship with frail medical patient, do y'all have any sort of resources or any sort of programs you put your frail patients through to like make them healthier? You know, I can rehab or anything?
There's no, here, do this for 6 visits, get better. There really isn't. And frailty is usually something that doesn't happen overnight. It happens over a period of months to years. So to reverse that or change that is really complicated. We try to take a social aspect to support. So why are they losing weight? Are they completely cognitively impaired and don't have a caregiver? You know, it's a different approach. It's not something we think we can always change, but we seem to think from a modification, what is modifiable? What can we get in there and do? Is getting home-based primary care involved in the home setting going to prevent further decline and institutionalization? So it's very complicated. It's not here, fix, do, get out. And so I think frailty does need to be measured. I think it's a really important question. I just would say try to figure out the right target group that you really feel like maybe cancer is the right target group for this. I don't think you, because I work at the VA too, and these vascular veterans have horrible outcomes. I mean, it's a factor of multiple things. And I couldn't say there would be anything to change some of their frailty status. You can't take away 25, 30 years of smoking or diabetes. I hate to say it that way, but you just try to modify.
For sure.
And sometimes the surgery is needed. It's an amputation, but that's what's needed.
You may have mentioned this, and I just missed it. Are you limiting this to certain procedures? So is it going to, are you going to include like gallbladders with major colon resections or?
Yeah, so what I would like to do to assess it at the VA is to do anyone who's over age 65, and I would actually like to lower that age. I say that, but because I think especially a lot of the veterans, their chronologic age and their sort of how they appear are so different. So really I would like to do it on everyone who's an inpatient surgery. I would like to do it on everyone.
Inpatient surgery.
Yes.
I would argue the converse of being a little bit more restricted to the target population.
Yeah.
Because then you have the alcohol, the substance. I mean, there's all the overlays that impact the chronologic versus
So the VASCLIP does a great job because they already measure all that. So you have all that on all those patients, because all of our patients, since our volume isn't so high at the VA, every patient is captured in VASCLIP. And so there's a trained nurse abstractor who collects all that data. So we have alcohol, smoking, we will have all that we can track over time. The problem is the only thing they currently collect is functional status, which again just doesn't.
How do they measure?
Very ambiguous.
It's very ambiguous. So they try to look through the medical record and see if there's any report of prosthetics consultation where they have a wheelchair or something. I mean, because no one else documents it, so it's not well defined.
So someone could be poor functional status without a hip replacement and left the hospital with a walker for short-term rehab.
Right, and then if they came back in with a bad gallbladder, and so the timeline that the nurse abstractor saw was discharge on a walker, readmitted, now needs surgery, this surgery, but they're on a walker, so they may come on partially depending, right? Whereas if the gallbladder hadn't been bad for another 3 months, they would have been fine.
I almost think that these issues that you're getting at in this pilot are so critical. You could really do all 3 aims on trying to define frailty better so that there can be an intervention.
Mhm.
It almost seems like you're going to need a lot of information about the measure in the surgical setting, how you're going to define the population you're going to be focusing on. It seems like there are going to be a lot of questions, and also you said that sometimes you might use frailty as part of the decision, but you also could intervene in some cases to improve outcomes somewhat. Elaine is saying also that there may be some instances of frailty where you can't reverse them, but I'm not sure that it's clear that if you can, with one of these not reversible people, if you can improve their status enough just by some walking and engagement for a month or so before surgery, maybe that does improve outcomes. But all of those are ifs, so you'd have to demonstrate these things. And you might be, it might be really important in this study to figure out what level of frailty you're going to aim for and what age groups. It also seems like potentially it could be valuable to have some kind of integration of care as part of prehab. And you've said, MOVE would be great, but they really are not doing the right things that are really going to help. But having, looking for others, like maybe geriatric medicine is an important component, or there might be another service, or physical medicine. They might be important adjuncts.
And I had the pre-anesthesia clinic on one slide because the anesthesiologists love this idea of the surgical home and coordinating care around the time of surgery. That currently doesn't exist at our VA, but Charles Graham, who's one of our anesthesiologists there, is very interested in this topic as well and helping me with it. So I think that they could potentially help track and coordinate. The other option is the surgical clinic just plays the quarterback, so to speak, helping manage different appointments and visits and logs of exercise or whatever.
Can you get back to your first thing? No, I think this is really important. I really don't want to be negative, because I do think you could come up with either using a tool or refine the current tool to make this more applicable. I would just caution throwing in all surgical patients, knowing from your data that there are different outcomes for different groups.
Yeah.
But I think there is a way to do, because this is your aim, you're trying to do it administratively, right?
Yes.
Using administrative data.
Although, so it is administrative, but the VA, you get more from a retrospective VA study because we do have that corporate data warehouse information. And the VASQUIP data, is nurse abstracted, so it's not just billing codes.
Okay.
So someone physically looks at the chart and records things. Okay. So it's thought of as more reliable than, Medicare database. And we do know that, so in our readmission cohort, 12% of the cohort was frail when we calculated the modified frailty indices. So, it was like 140,000, so 12% of that.
So you want to take that 12% and look at outcomes.
Yeah.
In the thing.
And try to sort of understand the relationships better, and we have all that the other comorbidities and social behavioral aspects.
And this is using the rates of a frailty measure that you currently have been using, not one that you're going to use.
Correct. So this would be using the modified frailty index, which, as far as I can tell, is the only one you can really get from retrospective data that's been validated, because the others you have to have asked questions of the patient, so you can only get that with a prospective study.
Can you look at, did they get physical therapy post-op?
We can absolutely look at that.
Because I think that's going to be an important piece that's potentially modifiable.
because I think discharge destination ought to be one of the main endpoints.
Absolutely.
So if you could prevent, if you can keep patients at, either improve their functional status or keep them where they are so that we don't hurt them around the time of surgery and they can go home back to their usual kind of state of health rather than to a nursing facility, I think that's important.
And how long are you going to look for outcomes up to a year?
Yes, so, yes.
Oh, so this is with the retrospective data.
Is this what HSRD kind of grant is this? Just
A pilot, yeah.
Just a pilot, okay.
Mhm.
Okay. So I think this is a great pilot aim based on all your data and accessibility to that. I think that really makes a lot of sense. And then in the same vein, you want to pilot how to capture this
Right.
in the real world.
Mm-hmm.
Can you
Go ahead.
could you flip to your other aims just really quickly? I have a question, but I just want to
Yes.
them one more time. Okay. So I think, and I apologize in advance, I think this is a really dumb question, so I'm just going to apologize to begin with. But I think when you started this, I really thought your aims were going to have prehab in them, and I just kept saying frailty, and I think I'm confused as to, are you exploring the role of frailty in surgical outcomes or prehab in surgical outcomes, and how does this all connect at the end?
Right. So I think, and the title has evolved and won't be what it is on this slide. But, again, when I think of my big prehab dream world, when we started talking about, designing a project, we thought about tackling a lot of things, right? Like making a patient level specific checklist. So if you're a smoker, you go to the tobacco cessation clinic. If you're obese, you go to the MOVE clinic. If you're this, you go to this clinic. But we realized that was too much to figure out all at once. So the goal would be to work on separate pieces of things that you could modify before surgery to improve postoperative outcomes. And frailty seemed like one that that we could study, design an intervention, and track.
I think she makes a really good point.
Mm-hmm.
And I know prehab is the goal. And I think it's a good goal. But this is carving out a piece of who should we give that to,
Yeah.
potentially.
Mm-hmm. That's a good point.
And I do agree with that, but this is much more aimed at defining and intervening in
Mm-hmm.
a specific aspect. And it may be that a simple physical therapy visit or two is enough. I don't know the answer to that. And that's never simple. I should never say simple.
I mean, I think my concern from a grant perspective is the story you were telling didn't lead to the aim. And I think both are equally interesting, don't get me wrong. Prehab sounds like it is a great thing, and assessing frailty sounds equally as interesting to me.
Mm-hmm.
But there was some disconnect between the story that was motivating the aims, if that makes sense. And I do understand the relationship between frailty and prehab, but, sorry. And then I'm done. I'm
That's
sorry.
good.
I think I feel excited by what you've described in terms of understanding frailty, and we've talked about this, the general concept of prehab a lot together, and this actually seems like a potentially compelling focus that others aren't really pursuing. So all of that is great. So now that you have focused on frailty, conceptually, I wonder if the concept is going to change. It still might revolve around what you're doing before surgery, but the focus is now much tighter on frailty and it sounds like needs to become tighter still.
Mm-hmm.
So, but a pilot study, which is $100,000 in 1 year, would allow you to do some of that focusing to work toward, it could be implement, it could be that we need to do measurements of frailty to know what, in the pre-op setting, to know how to help these individuals with their decision-making as well as their activities before surgery. But you don't really know how you're going to define your measure, what is the best measure to use. And then you also need to refine your focus in terms of the population.
Mm-hmm.
Because it could end up being all over the place, people where they would need, move and smoking cessation and all these other things that really would be hard to implement in there are compelling reasons to implement some of these things in the pre-op setting, partly because, as we've talked before, people usually want to have surgery when they're coming to their surgeon, and they're motivated at that point to make some changes or to do things to make themselves healthier. So, that's a plus of that setting. But no one has been, this one program in Washington is assessing this multi-component program, but they're not really tracking outcomes. We don't even know if it matters. So this is a much more refined focus, and I think in that way it's a lot more compelling than the broader focus. But I think you'd have to decide about the aims, and a 2-aim pilot is not unreasonable if you just were going to do 2 major aims, thinking about how much time each one would take. Or a 3rd aim could potentially be one where you would do some exploration of, maybe through patient interviews, with what people feel they can do in this setting. So people who are frail, what do they want to do? What can they do? Would this be acceptable to them to see a physical therapist or see, or do an exercise program before they come in for surgery? I don't know how others think about this. If there's any similar thought to what I'm saying.
I would agree, and I would even say you're implementing this tool would be a feasibility. Is it feasible?
Mm-hmm.
Even for a pilot, what kind of data are you really going to get in a year?
Right.
But do people adopt it? You could even not just interview patients, but also providers.
Mm-hmm. That's a good point.
And that would be in aim 2 then,
Or aim 3.
Aim 3.
Yeah, like really just look at administratively, then pilot it at site level, clinical level, and really look at the implement. Like, is it nurse driven and is it provider driven? I mean, who's giving it?
That's a good point.
How do you? What is the feasibility of putting it into play? Is it CPRS note template that you just attach? I mean, how do you actually facilitate it in the clinic?
Mm-hmm.
And then you can talk to either providers and or patients to see what their thoughts are.
Yeah, that's a good point.
All of those are good ideas for pre-intervention, and part of the intervention is the measurement.
Right.
But there is the issue that you're not sure about the measure, which measure to use, and is that part of what you'd collect? You'd collect data here on both measures or just on the one measure?
The 2 frailty tools, you mean? Assessment tools?
Or you've decided on the one?
I mean, I think simple is better,
Yeah,
especially in the setting. And I don't want to disagree, or I just would go with the one that has the best evidence for your patient population, if at all possible.
Yeah.
And if not, there you go.
That's right. No consensus, so we could try to build some consensus. There's definitely a gap in the surgical literature and world.
Yeah, and I just from hearing from a resident's perspective, like I want to think, just knowing some of the being kind of on the groundwork of doing this, I want to think this is really a study to find out which measures are the best one, because I think that would take a separate study and trying to figure out, the feasibility, the time, the burden, all those things. I think it's just, you can, like you said, you pick a measure that fits with the surgical population and say, hey, this is a validated tool, we're going to use this because that's what a lot of people do, and I think it works fine. But I guess my question for Monica is, do you think it's a language issue of talking about prehab, and then never seen prehab. All you see is frailty.
Yeah.
Because the two are like one and the same. You say, we are prehabilitating our patients in their frailty to have better outcomes. Yeah. So it's more of a language on the aims you think would be important, or totally separate stuff?
I wouldn't write it the way I presented it. I just wanted to give sort of the background of like what we've been working on to kind of say how we've gotten to where we are. I was more telling that story than a cohesive study on frailty, or cohesive story on frailty.
I think the most convincing part of it to me was it sounds like you're incrementally going to build stepping stones to what's essentially like a perioperative surgical home, right?
Yes.
Which is, wonderful. I think it was just, throughout the beginning, I think I was leading myself up to, like, what is the prehab going to look like and how is that being implemented? And then I kept thinking it was about frailty. And so I think if you could just sort of switch to like the long-term goal by doing this, is so eventually we, have stepping stones to get to a perioperative surgical home, which is a very compelling story. And I think that's this is a pilot grant.
Right.
And this would be an ideal population to try a prehab program in. So it's defining target population better.
Sure.
So defining a target population and feasibility of measurement.
Those are great points.
I just would be careful that frailty isn't always, like I said, just there isn't a lot of data to suggest that we can change it. We recognize it. It's a recognized condition like diabetes, if you will.
Sure.
We modify it, but we don't necessarily. We can potentially, but there isn't a lot of outcome data to support that.
That's right.
The one outcome that you mentioned that I've seen that has the most movement for prehab is rehab post-op.
Yes, that is true. Rehab post-op, getting people out of bed, getting them in a chair to eat their meals, avoiding delirium, all of that.
Sure. Yeah.
Is what we do for frailty.
Right.
In the post-operative setting.
So I'm actually involved in the virtual ACE unit over at UAB and the implementation of that on all our surgical patients, and we'll be tracking that over time. So this will sort of help build into the work I'm doing over there as well.
Absolutely, because that's where we don't have a lot of data to suggest pre-op, but what we do is try to modify post-op.
And again, there are a few studies in colorectal cancer patients that just walking helped them decrease their length of stay, and it did improve some of their postoperative outcomes. So.
Absolutely.
And I think, maybe the cancer frailty, maybe that's different than just elderly frailty. So maybe there are certain groups where it would be important for, but we don't know that at this point.
I just see that as being frailty in a defined period versus frailty that's come over a lifetime.
Right.
Those are different to me.
So the 95-year-old who can't walk anymore is not going to walk, right? Probably.
Well, no, not without some assistance.
Right. But the 65-year-old who was diagnosed with colon cancer, but it's been brewing for a while, and they've had this progressive decline because of it, maybe.
Yes, they have a potential for a huge rehab.
Yeah.
So it sounds like it's optimizing people.
Yes.
Like reach them maybe the best that they can reach, but it's not going to be, they're not going to be normal, but.
I think that is great.
Oh, thanks.
I did want to mention that, too, and I think you already know this, the review panels in the VA HSR&D have very few surgeons on the review panels, and they have a lot of geriatricians on those panels.
So I need some geriatricians to read it before I submit it.
Yes.
Yeah, or even put geriatric. Honestly.
Yeah.
I would reach out to that group because you're right.
I think that would give it credibility
That's a
to
good
the
point.
reviewers to have someone on the grant at some percent to, or even someone who has expertise in frailty measurement now. But I'm very excited about what you're doing. This is really
Thank
great
you.
work.
Thanks everyone for coming.
Thank you.
This was very nice. That helps.
You did, absolutely, thank you.
I presented earlier this week.
Oh.
Yeah. I'm working on my own.
No.
Yeah. Good luck. Thank you. Let me know if I can help.
Thank you, I appreciate that. That's right, you might be. You know what, we're actually gonna